Hello, everyone. I'm just going to share my screen. And so. Perfect. Hello, everyone, and welcome. My name is Dr. Alexandra Kopelovich with Physiogram e-learning. Very happy to have all of you here today. Thank you so much for joining us. I hope you enjoyed this webinar. Today, we will be discussing clinical gait analysis, and the specific topic for the presentation is essential range of motion during gait. Now, this is our third webinar. So initially we covered temporal variables, we covered distance variables. Now we're going through the ranges of motion. So we will discuss normal range of motion as well as abnormal range of motion. And the following time, we'll be looking at trunk and upper extremity movement. So I hope you'll be able to join us for the following webinar as well. And I really hope that you find it useful and be able to clinically apply it right away to your clinical practice. Or if you're a student, hopefully you get to relearn the range of motion in this webinar. So let's get to it. Just a few things. Just keep yourself on mute for the duration of the presentation, just because it's obviously distracting to other people. And if you do have questions, I have my full screen here, but I cannot see the chat window. Just keep your questions up until the end, and I will answer all of them gladly. Alrighty, so just quickly about myself, I am a doctor of physical therapy. I graduated from Touro College in New York in 2014. I am a orthopedic specialist since 2017. I've been doing my manual therapy fellowship, and hopefully this summer I will be finished with my manual therapy fellowship. And I'm also working on my dissertation and my Doctor of Science degree from Andrews University. My dissertation will be on muscular analysis of ballroom dancers. If anyone has any interest in that topic, please speak to me personally. Just message me. Alrighty, so let's talk about the central range of motion during gait. Our objectives for today is that, of course, we will define the gait cycle. We will identify the phases of the gait cycle as well as subdivisions. We will examine the normal, healthy, quote unquote, range of motion. And as well as abnormal gait patterns. So we'll take a look at, I'll give you some video examples of abnormal gait patterns, as well as we will examine common deviations and compensations for the lack of range of motion. So I think it'll be interesting to students, but as well as obviously physical therapists. Sometimes we tend to miss these things in the clinic, and it's interesting to always come back and just see it one more time. So let's take a look at our case study. I always like to present the case, even though it's only range of motion, but it's not fun just going through the numbers. So we're going to study this case throughout the entire presentation, and we'll be examining the range of motion specifically related to this case, but I'll give you a couple of more cases of abnormal gait. So in this case study, patient presents to your clinic complaining of right knee pain when walking. And this is the type of gait you observe. This patient was kicked a few days ago while playing soccer. So, and the patient was kicked in the right knee. So just take a look at this patient ambulate. So there are some objective findings that I've put down for you. The right knee, you found effusion. So obviously there is swelling. You measured that was a tape measure. In terms of range of motion, you found full active range of motion and passive range of motion of the hip and ankle joints, which is interesting because in this video, you can definitely tell that the hip is flexed for the duration of the entire gait cycle, as well as ankle. Ankle maintains pretty much in the dorsiflexed position, but passively and actively as well during normal measurements, these measurements are okay of the ankle and hip. Passive range of motion of the right knee was found to be negative 30 degrees. So patient is unable to get to 0 degrees of full extension at the knee. And that is once again obvious and confirmed throughout this gait cycle. So we're going to do a poll right now. To what can you attribute the discrepancy between the passive range of motion measurements of the hip and ankle and active range of motion in gait? So basically, one more time. So when we're looking at this patient, she presents with flexion at the hip and dorsiflexion at the ankle throughout the entire gait cycle. But this patient has full range of motion, passive and active at the hip and ankle. So what are some factors that you can think of to what you can attribute the discrepancy between passive range of motion measurements of the hip and ankle and active range of motion in gait? Is it false passive range of motion measurement? So I didn't do my measurement correctly. Is it a compensatory strategy? Or is it a normal finding to have a discrepancy between passive range of motion and active range of motion during gait? So I'm going to start the poll and launch. Okay, so you can answer it right now. Answers are coming in. And I'll give you 30 seconds to answer that, so we don't take. And I'll move it away so you won't see it on my screen as well. All right, almost there. I'll give you 5 more seconds for anyone else who wants to submit their answer. All righty. So the correct answer is compensatory strategy, and 83% of you got it right. And that is absolutely correct. Yeah, sorry, I am. Sometimes, yes, we make mistakes, but in this case, I didn't make a mistake for false passive range of motion measurements. So yes, this is a compensatory strategy. And let me just close this off and tell you why. So obviously, when the patient goes, when the patient's knee is swollen, right? So it's swollen, the patient is unable to extend it completely. It's negative 30 degrees. His center of gravity is shifted. So what has to happen? The line of gravity has to always maintain within the base of support. So this is exactly a compensatory strategy to maintain that line of gravity within the base of support. I hope this was clear to everyone. And okay, so let's start looking at the gait cycle. Let's cover some terminology. As we know, walking is a result of cyclic series of movements, and gait cycle is a fundamental unit of walking. Gait cycle is defined as a time from contact of the right heel to the time the right heel contacts the ground once again. So it's the same lower extremity contacting the ground. Here, the gait cycle is identified from 0% to 100, and that's an entire gait cycle here, marked here with a green arrow. The gait cycle is divided into 2 phases, the stance phase, and obviously that's when the foot is completely on the ground, and the swing phase of the gait cycle, and that's when the foot is off the ground. Stance phase takes up 60% of the entire gait cycle, once swing phase takes up 40% of the entire gait cycle. Let's take a look at some sub-phases of these events. So we have under stance phase, we have 5 events that are occurring. Initial contact, and that's when the heel typically contacts the ground. That occurs at 0% of the gait cycle. At 8% of the gait cycle, we have foot flat. That's when the entire plantar aspect of the foot contacts the ground. Following that, we have mid-stance, is when the greater trochanter is completely vertically oriented over tibia. That's at 30% of the gait cycle. And as you can see, I told you that the stance phase of the gait takes up 60%. So mid-stance is exactly at half of 60%. So that's something to note. Heel off occurs at 40% of the gait cycle, and that's when heel leaves the ground. Toe off occurs when the toe leaves the ground, and that's at 60%, finalizing the stance phase of the gait. Then we go into swing phase of the gait, and we have, once again, 3 events occurring at the swing phase. We have early swing, 60 to 75% of the gait cycle. We have mid swing, 75 to 85% of the gait cycle. And finally, late swing, 85 to 100%, completing the entire gait cycle. One thing to note about the swing, in some of the slides, it depends on the terminology you use. Some of the slides I refer to early swing as acceleration and late swing as deceleration. Once again, just terminology. The events are actually the same. So let's take a look at what it looks like in real life. So all these events, and I'm going to mark it for you. So here we establish contact with the ground. This is initial contact, the beginning of stance phase. Slowly we're moving into foot flat. Now mid stance. Following by heel off. You can see how the heel leaves the ground. Toe off. Now the foot, we're moving into the swing phase of the gait cycle. Early swing, mid swing, when 2 feet are right next to one another, and late swing, preparing for landing. So this is your entire gait cycle. So for this presentation, I was really trying to stay true to range of motion, but it's really hard to talk about range of motion without incorporating some other things like ground reaction force and muscular activity, because they're so closely related. So I will just briefly touch on the line of gravity and ground reaction force. I think for most of you, it's probably going to be a review. And this really impacts how you view gait. So I think it's an important topic to bring up. In postural analysis, the position of line of gravity helps us identify muscular activity or identify which ligament is going to be tense. Typically, we are all familiar with this picture, the line of gravity, or otherwise known as a plumb line, typically runs through every single joint of the body here, or at least pretty close to every joint of the body. So if the line of gravity runs through the joint, typically it does not require much muscular activity. The further the line of gravity runs from the axis of rotation of the joint, the more muscular activity it will require. What line of gravity does, it basically acts as a force on the proximal segment and tries to rotate the segment. So let's take a look. It's a lot of words. Let's just take a look at the example. I think it's going to be a little bit easier. Let's take a look at the ankle joint. So this is basic quiet standing here. So here's a red circle right here, and this is the axis of rotation of the ankle joint, talocrural joint. Now we have the red line right here, long red line demarcating the line of gravity. So you can see that the line of gravity is just anterior to the axis of rotation. So it doesn't go right through it like at the knee joint, it goes right through. At the ankle joint, it's just a little bit anterior. So what it does, it creates a dorsiflexion force. And how it does it, it tries to pull, follow this blue arrow, the distal, the proximal component of the joint into flexion. It tries to pull it anterior. So we know that the ankle joint is made up of talus, articulating with tibia and fibula. With that, we know this is the proximal component, tibia and fibula. So if the line of gravity lands anterior to the joint, it will pull tibia and fibula anterior. So we constantly, actually, in quiet standing, have that anterior force trying to pull tibia and fibula anterior. And this will create a dorsiflexion moment at the ankle joint. So what our body does, it has to go to a stabilization system. So the first line of support would be ligaments, but there is no real ligaments that can prevent that dorsiflexion force at the ankle. So the next system of support would be the muscular system. So here, if you were to perform an EMG activity on the ankle, you would see a constant isotonic activity of soleus because it prevents the ankle from falling into dorsiflexion. So soleus is constantly active during quiet standing. Let's take a look at another example. Let's take a look at the hip. So here, this is the red dot indicating this is the axis of rotation of the hip joint. The line of gravity, the blue line, is located slightly posterior to the axis of rotation of the joint. Now, if it's located posterior to the axis of rotation of the joint, it wants the distal segment to rotate posterior, to rotate backwards. So it wants, the hip joint is created by the femur and the pelvis. So it wants the pelvis, because that's the proximal component, to rotate backwards. So if the pelvis rotates backwards, that creates an extension moment at the hip joint. So what our body needs to do, once again, we go to our primary restraint system, which would be ligamentous support. And in this case, we have our iliofemoral, ischiofemoral, and pubofemoral ligaments that are all responsible for extension restriction. So they all will be stabilizing us right here anteriorly and posteriorly to prevent that excessive extension of the pelvis. So you will see that these ligaments are slightly tense during quiet standing. Now, let's take a look at this example. What if I really pull the line of gravity back? What's going to happen? That's going to increase the amount of force acting on our joint, meaning that here the ligament stability is not going to be enough anymore, and we will have to recruit our muscles. So there is a huge extensive force going through, going right posterior to the joint axis. So we need a larger or equivalent flexor force to negate that. And we will utilize iliopsoas in order to rotate our pelvis back into a neutral position. One more time, example for the ankle. So if the line of gravity is now excessively anterior to the joint, now gastrocnemius is unable to support the ankle just by itself. So we're gonna have to recruit more muscles. And in that case, most likely soleus is not gonna be working alone anymore. It's gonna recruit gastrocnemius. So that's the order of recruitment. So the further away the line of gravity from the axis of rotation, the more work our body has to do, the more muscles our body has to recruit. Why am I speaking of posture when we're doing gait range of motion? So basically, the line of gravity is very similar to the ground reaction force. Ground reaction force is an equal and opposite reaction to you stomping the ground when you're walking. And this is exactly what it does to our joints. So it's either landing anterior or posterior to our joints. And depending where it lands, this is the muscle group that's going to be active. But also, it's not only the ground reaction force that we're looking at our ankle. What if I excessively plantar flex the ankle? Where does this position the ground reaction force? What if I excessively flex the knee? What happens to the ground reaction force then? So you can see that there is constant interaction between range of motion, ground reaction force, and muscular activity. So the goal of healthy gait is to optimally utilize the musculature, which means keeping the ground reaction force as close to the axis of rotation as possible. So let's take a look at the range of motion. Okay, so now we're looking at initial contact. And this is pretty simple. If there are any students listening right now, I would suggest instead of memorizing these numbers, it's really much simpler to stand up and actually do it. And I think once you do it and you bring up that kinesthetic awareness sense, you're going to be able to remember it better. So just a tip for the students. So once again, looking at initial contact. So the whole point of initial contact is to establish contact with the surface, to initiate weight acceptance. How do we establish contact with the surface? We really need to elongate the entire lower extremity. So by flexing the hip, extending the knee, and being neutral at the ankle, we're really stretching out our leg to be able to land as far possible and as inefficient possible. So here's our range of motion once again at 0 degrees at the ankle. We're neutral here. We're neutral at the knee, 0 degrees. and 20 degrees of hip flexion. Let's take a look at our case study. I am going to pause it when the patient goes through initial contact. Just try to eyeball it yourself, initial contact, and here we go. So this is our initial contact. That looks way different from what we just saw 2 seconds ago, right? So let's take a look. This is how our patient with knee fusion establishes initial contact. So this is the norm. This is what you saw just a second ago. And the blue values are the norms as well. So we're expecting neutral ankle, neutral knee, and 20 degrees of hip flexion. So once again, you're expecting the patient to completely extend their lower extremity to go as far as they can. Let's take a look at what's happening. 25 degrees of plantar flexion at the foot. Obviously, that's not what we're expecting. Excessive flexion, 29 degrees of flexion at the knee joint, and 61 degrees of flexion at the hip joint. So everything is excessively flexed, okay? Now, you can see the angles right here, and these angles also will demarcate the axis of rotation of the joint. The green line here will be the ground reaction force. So similar to the line of gravity, what we discussed 2 seconds ago. So now what I want to do, I'm going to do a poll of what you think is happening to the joints with this kind of ground reaction force. So let's take a look. So this is our first one. Based on the ground reaction force in relation to the ankle, so right here, which primary muscle would be active initially? So once again, so this is the axis of rotation of the joint. This is the ground reaction force, and it's anterior to the ankle. So based on this ground reaction force, which muscle do you think will be active? So let me start pull, ankle ground reaction force, lunge. Okay. And I'll give you 30 seconds to answer that. And the room seems to be a little split right now. Okay, let's go for 10 more seconds. Anybody who needs to answer? And end. Okay, so this is our poll, and this is what it came out to. So, wow, it's very much split. Okay, so based on the ground reaction force in relationship to the ankle, which muscle would be active initially? So we have soleus, tibialis anterior, extensor digitorum, and gastrocnemius. Now, the correct answer is, I'm sorry, 44% of our audience is not tibialis anterior, it's actually soleus. And why is it soleus? So it's exactly what I told you was the center of mass and line of gravity. Take a look. So this is the axis of rotation of the joint at the ankle. If the ground reaction force lands anterior to the ankle, it will tend to pull tibia and fibula anterior, which will create a dorsiflexion moment at the ankle joint. What it does, it pulls it anterior for dorsiflexion. So we need to use our opposite muscle group, so our plantar flexors, in order to counteract that force. So we will either use gastrocnemius or soleus. So these would be the two answers that I would be split in between. Now, how do we know which one? Typically, our body goes to recruit single joint muscles first. So soleus would be our go-to. Gastrocnemius would not be our go-to because there's too much energy expenditure with two joint muscles. It will also act on the knee because gastrocnemius crosses the knee, and it will tend to pull the knee into flexion. So the correct answer, the primary muscle that will be active here, is soleus. Okay. So let's take a look at another one. So here, based on the ground reaction force in relation to the knee, which muscle would be active initially? So we have 4 choices, and I'm gonna launch the next poll. And knee ground reaction force, launch. Okay, so we have 4 choices: adductor magnus, popliteus, vastus medialis, or TFL. I'll give you 30 seconds to answer. Okay, now the room is not so split, where I think we're in between 2 answers. All right, I'll give you 5 more seconds. And end. Okay, so let's take a look. So based on the ground reaction force in relationship to the ankle, to the knee, which primary muscle would be active initially? First answer, adductor magnus. Second answer is popliteus, vastus medialis, or TFL. So the correct answer is vastus medialis. So 67% of you got it right. Why is it vastus medialis? Let's take a look. Let me move this aside. Okay. So here's the axis of rotation of the knee joint. The axis of rotation is anterior to the ground reaction force. So the ground reaction force is posterior to the axis of rotation of the joint. Now, think about the knee joint. What is it made up of? It's made up of femur articulating with tibia. So the ground reaction force wants to pull, if it's posterior, wants to pull the proximal component into posterior direction. So if we were to draw a line here, moving posterior, pulling the femur back, it will create a flexion moment at the knee joint. So that external flexion moment created by that force, by the ground reaction force, has to be counteracted. And what we will use is our extensors in order to counteract that force. So the best answer here would be vastus medialis, because it's part of our extensor, quadricep group. And the second answer was popliteus. Popliteus would be the correct answer if the line of gravity was anterior to the knee joint, not posterior. Good job, everyone. Okay, and I think we have one more to go. So based on the ground reaction force in relation to the hip now. So now the ground reaction force is here. I'm just not gonna say anything. In relationship to the hip, which primary muscle would be active initially? I'm gonna launch the poll. You can read the answers meanwhile. Okay, and I'm just gonna pull it aside. Go ahead. So based on the ground reaction force in relationship to the hip, which primary muscle would be active initially? Is it gluteus medius, iliacus, psoas, or gluteus maximus? And I'll give you another 10 seconds for this. Alrighty, let's take a look. Based on the ground reaction force in relationship to the hip, which primary muscle would be active initially? So most people said gluteus maximus. Some people said psoas, iliacus, and gluteus medius. Okay, so the correct answer is gluteus maximus. Why is it the correct answer? Here's the axis of rotation of the joint. Now let's take a look at the ground reaction force. It lands anterior to the axis of rotation of the joint. Now we know that it will pull the proximal component of the joint anterior. So what is the proximal component of the joint? We have femur articulating together with the pelvis. So it will pull pelvis anterior, creating a flexion moment. So it's an external flexion moment that's going to occur at the hip joint. So what do we have to do to counteract that? We have to use our extensors in order to prevent the pelvis from buckling forward. So the correct answer would be gluteus maximus. Also, it would be the primary muscles active because it's mostly active in the sagittal plane. Gluteus medius would probably be the secondary muscle active, but gluteus medius acts more in the transverse plane and as well as the frontal plane as the abductor. So that wouldn't be the primary muscles active. But good job, everyone. Let's continue. So now we're looking at foot flat. With foot flat, we can see the first thing you should notice that everything goes into flexion. We have 5 degrees of plantar flexion at the ankle joint. We have 15 degrees of flexion at the knee joint and 15 degrees of flexion at the hip joint. So everything moves into flexion. And you have to know the reasoning. Why does it move into flexion in the first place? So the function of this flexion is weight acceptance and shock absorption. Obviously, because the joints move into flexion, it allows that shock absorption. If your knee was completely extended, there would be absolutely no shock absorption. So it makes sense that we're in 5 degrees of plantar flexion, 15 degrees of flexion, and 15 degrees of flexion at the hip joint. Let's take a look at what it looks like on our patient, in our case, and foot flat. This is what foot flat looks like on our case. And here are the values. So obviously, very different picture from what we're expecting and what we're actually getting in the clinic. The blue ones, once again, they're normal values, same values as these. So we're expecting 5 degrees of plantar flexion, 15 degrees of knee flexion, and 15 degrees of hip flexion. What we're getting is 19 degrees of plantar flexion, not the same, 23 excessive knee flexion and excessive hip flexion once again. Let's move on to mid stance. At mid stance, we need to, it's responsible for single limb support and stability. So everything has to be more or less, quote unquote, locked out. So the hip is going to be in 0 degrees of flexion. The knee is going to be in slight flexion, and the ankle is going to be in 5 degrees of dorsiflexion. And you have to note that this 5 degrees of dorsiflexion, typically the texts say 5 to 10 degrees. So just keep in mind that there's obviously a range for these values that are not set in stone. But 5 degrees of dorsiflexion is what the patient needs for healthy ambulation. So like I said, so when you actively and passively check patients' dorsiflexion, you know that the number has to be about 5 to 10 degrees, and this is the number you will be reporting to the insurance company. So let's take a look at what mid stance, and if our patient actually gets to that dorsiflexion, knee flexion, and hip flexion, and this is, we call the patient right here at mid stance. Here's the picture of our patient in mid stance with all the values. So we're expecting 5 degrees of dorsiflexion. Our patient is actually in 10 degrees of plantar flexion at this point. We're expecting 5 degrees, very slight flexion at the knee joint, but our patient is at 17 degrees of knee flexion. And we're expecting 0 degrees at the hip joint, but we're getting 25. So it's a lot more. So once again, coming back to all those, to our pop quiz, what I gave you is that you know that what muscles will be overworking. We know that there is going to be excessive activity of gastrocnemius and soleus because it's the line of gravity, the ground reaction force, is constantly anterior to the ankle joint. Now, the ground reaction force is constantly, since initial contact, foot flat and mid stance, is constantly posterior to the knee joint. So we know that the quadriceps will be overworking as well. And finally, we know that the gluteals will be overworking together with the rest of the muscle groups because the line of gravity is constantly anterior to the hip joint. And if we look at normal gait, and like I said, the point of today's presentation is not to go over muscular activation, but if we do examine normal gait, we see that muscles constantly change from initial contact to foot flat to mid stance. We constantly have its quadriceps, hamstrings. There's constant change. And if the patient maintains the same muscle group activity for the duration of the entire gait cycle, that will not only fatigue the muscle, that will stress the joint or the joints that the muscle is crossing. So there is a lot of outcome that's happening, and this patient will most likely present with patellofemoral syndrome because the quadricep will definitely compress the patella into patellar notch. Patient might present with knee pain as well, lower back pain because the rectus spinae will be overactive. Patient will present with sacroiliac pain because the gluteals are constantly overactive. So there is a lot of consequences to this simplistic, I would say, posture when, oh yeah, he just has a little bit of flexion, but it's not just a little bit of flexion. It has a greater outcome. So let's take a look at heel off. At heel off, we have 0 degrees of dorsiflexion. We have 0 degrees at the knee joint and 20 degrees of extension at the hip joint. So it's completely opposite of what we just saw at mid stance. So at mid stance, we were kind of a little bit flex, 0 degrees of flexion at the hip, a little bit of flexion at the knee, a little bit of flexion, dorsiflexion at the ankle joint. Now we're going into complete opposite. We're going into more plantar flexion at the ankle because we go from dorsiflexion to plantar flexion. We go to extension at the knee, so we're locking out the knee to prepare for propulsion, and we're going into extension of the hip to prepare once again for propulsion. So this would be the opposite of initial contact, right? With initial contact, you go into 0 degrees, you're completely extended forward, 0 degrees at the ankle, 0 degrees at the knee, and 20 degrees of hip flexion. So now you're doing the same thing, but trying to propel yourself forward with 20 degrees of hip extension. And the function here is single limb support and stability, and of course, propulsion, as I mentioned a second ago. Let's take a look at our case study. So this is clear. We don't even need to analyze it slow motion because it's clear that we're not getting enough propulsion here. We're not getting that heel off. So let's take a look at our normal values and the values that our patient got. We're expecting 0 degrees at the ankle joint, 0 degrees at the knee joint, and 20 degrees of extension at the hip joint. What we're getting is 15 degrees of dorsiflexion at the ankle joint. So finally, our patient is actually going through dorsiflexion, but it's a little bit too late. Now, our patient's once again in excessive knee flexion and 0 degrees of hip extension. So this will, of course, result in less propulsion, and it will shorten the step and increase the energy expenditure. So there is a lot of consequences to this tiny little knee flexion problem. Let's take a look at toe off. So with toe off, once again, we're getting ready. So with heel off, we're getting ready for propulsion. Toe off, we're going into propulsion now. So here we need to, propulsion actually comes from your plantar flexors. So we really need to plantar flex our foot to push off. So we're going into 20 degrees of plantar flexion. Now, we also need to clear our foot off the ground. So if we're creating all this length with the plantar flexion of the foot, something has to compensate to keep the limb a little shorter and to prevent that excessive vertical oscillation. So the compensation will actually come from the knee joint. And the hip joint is going into slightly less extension. It's going into 10 degrees of extension because it's getting ready for the swing phase of the gait cycle. Let's take a look at what our patient looks like. And toe off right here. So this is where the patient's ready to go into the swing phase of the gait. So these are our normative values, and these are the values of our patient. So once again, 20 degrees, we're expecting 20 degrees of plantar flexion, 0 degrees of plantar flexion. So our patient is completely not plantar flexed at all. We're expecting 30 degrees of knee flexion, excessive knee flexion once again, and excessive hip flexion. So once again, it will result in a shorter step length, shorter stride length, and slower speed of walking, as a matter of fact, as well. So here we're going to briefly look at the swing phases of the gait. First, we're looking at acceleration or pre-swing. So here, as we need to swing the lower extremity, we of course need to shorten the limb. So we're going into less plantar flexion, as was toe off. We were going into 20 degrees of plantar flexion. Here, we're in 10 degrees of plantar flexion. So we're slowly shortening the limb. We're going into more degrees of knee flexion. So we're going towards 60 degrees of knee flexion and more degrees of hip flexion. We're at 20 degrees of hip flexion. For mid swing, we're continuously swinging the limb, we're advancing the limb, but at the same time, we're keeping the limb short. So the ankle is completely neutral right now. So we went from 10 degrees of plantar flexion. Now we're at 0, we're at neutral ankle. We're going into a little bit more extension at the knee. So we are at 30 degrees of flexion because we're getting ready for that landing already. And we're at our 30 degrees of flexion, so that's what we're expecting to hit at initial contact. And finally, deceleration phase is very similar to the initial contact. Here, the function is to slow down the limb and prepare for the initial contact. So it's pretty much the values are the same as for the initial contact. So we're at 30 degrees of flexion, 0 degrees of knee extension, and 0 degrees of dorsiflexion at the ankle. So getting ready, once again, extending the lower extremity, getting ready to heel strike. So the next little section that I created for you are the clinically relevant range of motion during gait. And these are the values, if you're not a student, these are the values that you're actually interested in. And these are the values you're certainly going to be utilizing for your clinical setting. These values will help you report to the insurance company and keep track of your patient's progress. So let's take a look. Once again, I tried to make it as easy and as legible as possible. So let's get through it. So let's take a look at the hip sagittal plane range of motion. We're looking at the maximum values, but these are the values they need for healthy gait. So maximum flexion they need for gait is 20 degrees at the hip, and maximum extension that you need at the hip is also 20 degrees. So pretty simple to remember: 20 degrees of flexion, 20 degrees of extension, two values that you need for proper ambulation for normal healthy gait at the hip joint. When does it happen? So we strike the ground and we're at 20 degrees of hip flexion. So this is our first value. This is where we actually need the maximum range of motion at the hip. And the second value, the 20 degrees of extension, we need at heel off phase of the gait. So when we actually getting ready to push off and to propel our body forward, we need that full hip extension, which is about 10 to 20 degrees. Once again, it really depends what text you read and what numbers they report. Let's take a look at the knee joint. So knee joint sagittal range of motion. We need to go from 0 degrees to 60 degrees at the knee. So a patient's knee for a healthy gait has to be able to extend completely to 0 degrees and has to be able to flex to 60 degrees. If patient's knee doesn't flex to 60 degrees, in a few slides, we will take a look at videos and see what compensatory strategies they tend to use. Let's take a look at when do you need that range of motion. So you need 0 degrees of knee extension 2 times during the gait cycle. So that's obviously very important. And this is knee extension range of motion is one of the first things you typically will be stressing when you're working with post-op patients. So anybody status post ACL or any knee replacement, meniscectomy, all those post-ops, knee extension range of motion is the first thing you will be stressing. So you need knee extension for initial contact of the gait cycle. So just when you're contacting the ground. And once again, for heel off. So for 0 degrees at initial contact and 0 degrees at heel off. Maximum knee flexion in the gait cycle occurs during acceleration, which makes sense because you really need to shorten that limb and clear the entire limb, clear the foot to make sure you're going through swing without touching the ground. So 0 degrees at initial contact, 0 degrees at heel off, and 60 degrees at acceleration phase of the gait. And finally, ankle. So 2 ranges of motion you need to remember for the ankle joint. Maximum dorsiflexion is typically reported to be 5 to 10 degrees, and maximum plantar flexion for the ankle would be 20 degrees. So 5 to 10 degrees of dorsiflexion is a healthy range. Patient won't be ambulating with any compensatory strategies. 20 degrees of plantar flexion is your healthy go-to range. So when does it occur? 5 degrees of dorsiflexion, as I stressed before, occurs at mid-stand. So a lot of people would think that you actually need more dorsiflexion during the swing phase of the gait cycle. So don't be tricked. You need most of your range of motion actually during the stance phase of the gait cycle. And plantar flexion, we need most plantar flexion, which makes sense for toe off because you really need to push yourself forward. You're using those plantar flexors a lot to propel the entire body forward. So 20 degrees of plantar flexion is necessary for healthy gait. Now, let's take a look at some pathologies with limitations in range of motion and how it will affect patients' overall gait and other joint compensations. So I took 2 extremes for every single joint. So this way we go through all of them. So we have first one is the hip joint, where we'll be looking at limited hip extension and limited hip flexion and what it presents like and what are the typical compensations. Let's take a look at the first video. So this is what limited hip extension would look like. Just give you a second to look at it. So with limited hip extension, typically we will be compensating with a joint above or a joint below to gain that range. So in this case, the compensation comes from a joint above. So if you're unable to get hip extension through the femur, actually extending within the acetabulum, we will get hip extension through the pelvis. So the pelvis will go through anterior pelvic tilt. And that is actually a tricky compensation to spot because once again, because of clothes and because you really need to train your eye in order to actually spot that. So here I would say it's pretty hard to, it obviously looks off, but it's really hard to tell that patient is compensating for that decreased hip extension. But what you can see here is that not only this patient presents with anterior pelvic tilt, but also this patient goes into excessive lordosis at the lumbar spine, which is also another compensatory pattern for a lack of hip extension. So once again, if the patient presents with limited hip extension, and as we spoke about our values before, we need at least 20 degrees of passive range of motion at the hip and active range of motion as well. This patient will typically compensate at the pelvis, pulling the pelvis into anterior pelvic tilt, or compensate further up, go up to the lumbar spine, and create excessive lordosis, which will also create that hip extension moment. Now, let's take a look at the opposite. Let's take a look at the limited hip flexion scenario. And this is what it looks like. So the compensations for this one will be totally opposite from what we spoke about just a second ago. So once again, the compensations can be with a joint above or a joint below. So we'll be taking a look at a joint above. If the patient's unable to perform hip flexion for either weakness of the hip flexors, of course, or limitation in the capsule of the joint. So whatever the reason is for this patient inability to get to hip flexion, we will be compensating at the pelvis. So the pelvis will typically go into a posterior pelvic tilt, which is actually seen here. So as you can see, when we strike, when we need that 20 degrees of hip flexion during initial contact, take a look at the pelvis, how it posteriorly tilts every single time the patient moves into initial contact. Posterior tilt, posterior tilt, posterior tilt. So this is our compensation. Secondary compensation, just like with the previous case, can be that the patient is going into flattening of lumbar lordosis. So in this case, it's not really a scenario because he's really exaggerating that pelvic tilt, and obviously trunk motion will be exaggerated as well. And In both of these cases scenarios, we will of course increase the loading through the lumbar spine. So if you are going excessively with the pelvis excessively into posterior pelvic tilt and you're flattening lumbar spine, there's going to be excessive pressure at the anterior portion of the joint. If you're going into excessive extension, of the lumbar spine, as in the first case scenario, there's going to be excessive compression of the posterior structures of the lumbar spine, which is the Z joints or posterior disc. So these are the things that you need to listen up to your patient for. Patients will typically complain of lower back pain as well. But if you're going to jump in and just go into lower back and do your manual therapy on the lower back, it's not going to help resolve the issue. So you really need to look above and below and screen every single joint and find the comprehensive approach to your treatment. Now let's take a look at the knee joint. So once again, we have limited knee extension and we also have limited knee flexion. So let's take a look at some compensatory patterns. So this is actually the patient case scenario that we covered in this webinar. So our limited knee extension was secondary to patient being hit in the knee during soccer. What it does, it shortens the limb and it affects the standing foot as well as the moving limb as well. So with the standing leg, we already discussed it. What it basically does as a compensatory strategy, because the knee is constantly flexed, the hip has to go into flexion and the ankle has to move into dorsiflexion in order to keep the line of gravity within the base of support. So our center of gravity has to fall within the base of support, otherwise we will have no balance. Another thing that's happening, it overworks, obviously excessive overwork of certain muscle groups, especially quadricep muscle groups in this case. Let's take a look at the swinging limb. Swinging limb will also be suffering because if this, the standing limb right here is shorter, the swinging limb has to also clear the toes as the limb swings to prepare for initial contact. So in order to clear that, it has to shorten even more. So you have to flex more at the hip, the knee, or the ankle to clear the foot, because this entire lower extremity is now shorter because it's flexed. So compensations will be seen at the swinging limb as well as the standing limb. Another thing that you will see is compensation, because there is a functional leg length discrepancy between two legs. You will see excessive movement of the trunk, which will increase the metabolic demands of the body. So metabolic costs just rising because the entire lower chain, the knee, the hip, the ankle requiring excessive muscular activity. The trunk is also flexed forward. That will require activation of erector spinae and over compression of the lumbar spine. Let's take a look at the opposite. Let's take a look when the patient lacks knee flexion. So we know that most knee flexion necessary is 60 degrees during acceleration phase of the gait cycle. And here, patient is obviously not going through flexion at all. So it interferes obviously with toe clearance. This is our biggest issue. The knee has to flex to allow the entire lower extremity to go through the swing cycle smoothly. So what has to happen is, once again, compensations. Compensations will either happen at the joint above or the joint below. So at the joint above, we can see a compensation specifically for this example. The patient's going into hip hiking and quote unquote hip flexion, right? Trying to swing that limb over. So this way the toes don't actually touch the ground, because ankle won't be able to compensate as much as the hip. Secondary, because hip has more range of motion, of course, and more capabilities and bigger muscle groups in order to compensate. So that is why you're seeing more so compensations from the hip joint. So this is our limited knee flexion. Typically, we will see compensations at the hip joint as the lower extremity has to be swung through. And finally, let's take a look at the ankle. So first case scenario, we have limited ankle plantar flexion. And we know that we need most of our plantar flexion during the toe off phase of the gait cycle. And we're looking at heel off. Oh, just keep an eye out. So you see there's no toe off. We need 20 degrees of plantar flexion, and that's not happening. Basically, what that results in decreased push off, and it will lead to shorter step length in this patient. And obviously, patients going into excessive hip extension and excessive trunk lean, just trying to get that range of motion in. Alrighty, and let's get to the last one, limited ankle dorsiflexion. So with limited ankle dorsiflexion, this is obviously an extreme example, but you will see something like this in the clinic sometimes. This can be secondary to cerebral palsy, or it can be secondary to tight Achilles, for instance, or to a lesser degree after surgeries. You will see that as well. So it will cause a premature liftoff. So we need our ankle dorsiflexion, most of our ankle dorsiflexion during the mid stance of the gait. We know it's about 5 to 10 degrees of dorsiflexion that we need. So in this case, it will cause a premature liftoff because we can't even go to 0 degrees at heel off. So we will go into plantar flexion right away. And the compensatory strategy here is, well, there's no compensatory strategy because we're just swinging the other limb and going into hip hike of the contralateral lower extremity. Some other compensatory strategies, instead of just staying in plantar flexion, if you're limited in ankle dorsiflexion, you will also see people toe out. This gives you a little bit more range and lets you just go through the foot without having to go through the entire foot surface and completely dorsiflex the tibia and fibula over the foot. Another compensatory strategy for limited ankle dorsiflexion would be pronating at the midfoot. When you're pronating, once again, you're able to just create that quote unquote dorsiflexion and be able to get away with that. But in long term, we know that all these compensations will lead to muscular pain or joint degeneration. Alrighty. So now I have a few polls for you. I hope you're ready, and yeah, let's do it. So what is the necessary range of motion for the knee during gait? So this is everything we covered. Let me just pull up the polls and knee range of motion, launch. So this is everything we covered. Let's see. What is the necessary range of motion for the knee joint during gait? So this is the values we have to know. We're going to report them to the insurance company. So let's get these values down. Is it from 0 to 30 degrees, from 5 degrees to 50 degrees, from 0 degrees to 60, or 0 to 80? I'll give you another 10 seconds to go. Alrighty, I'm going to end the poll. Great. So most of you answered correctly. Great job. So it's from 0 to 60 degrees. We go to 0 degrees at the initial contact. We go to 0 degrees at heel off. And 60 degrees we see when we go into acceleration or pre-swing of the gait cycle. Excellent. Let's take a look at our next one. At which point of the gait cycle should the hip maximally extend? And I'm going to launch this poll. So at which point of the gait cycle do you expect maximum extension at the hip joint? Is it the mid stance? Is it foot flat, heel off, or acceleration? Let's take a look. I'll give you 20 more seconds to go. Almost there, and end it. Okay, so at which point of the gait cycle should the hip maximally extend? The answers are mid stance, foot flat, heel off, or acceleration. And most of you answered correctly. Great job. Now I definitely know that you listened to me, so that's great. So at heel off, we get the maximum hip extension at about 10 to 20 degrees. So that is correct. Alrighty. let's move on. Let me grab this. I have two more for you. Which one of the following would be a typical compensation for a limited hip extension? So this is from the last part of this webinar, and I'm gonna launch this one, hip extension, and launch. Okay. Which one of the following would be a typical compensation for a limited hip extension? Is it the anterior pelvic tilt, lumbar spine flexion, knee flexion, or ankle dorsiflexion? And I'm gonna end it. Alrighty, so most of you answered correctly. Congratulations, I am very happy. The typical compensation for a limited hip extension would be exaggerated anterior pelvic tilt, and that's what we saw with that video. Lumbar spine flexion would be a compensation for limited hip flexion. Same thing with knee flexion and ankle dorsiflexion. So anterior pelvic tilt will be the first go-to. Good job, everyone. Okay, last one to go. The patient presents with 10 degrees of plantar flexion, passive and active range of motion. Which event of the gait will be most affected? So your patient presents to you with only 10 degrees of plantar flexion, passively and actively. Which event of the gait cycle will be most affected? And launch. Alrighty, the answers are coming in. And I'll give you another 10 seconds to go. And end. Okay. So the answers are: the patient presents with only 10 degrees of plantar flexion, passively and actively. Which event of the gait cycle will be most affected? So we know that we need most plantar flexion during the toe off phase of the gait cycle. That's when we're going to 20 degrees of plantar flexion. So at heel off, we need 0 degrees of plantar flexion, so we're okay for that one. Mid swing, we need only 0 degrees of neutral ankle, and same thing, mid stance, we need 5 to 10 degrees of dorsiflexion. So the correct answer, 70% of you got it right. It's toe off. Great job. Alrighty, let me pull this aside. Okay, so that was the end of the presentation, and these are my references. And we will be I will be doing the next webinar on trunk and upper extremity movement during gait. And I will also be doing gait analysis, range of motion of the frontal and transverse planes. We do not have dates for these webinars set yet, as well as trunk and upper extremity movement will be the next webinar. No dates set yet, but we'll be posting a date soon on Physiogram. So also, if you have topics that you would be specifically interested in, please type them into the chat. I'm going to open the chat box right now. And if you have any questions, once again, in the chat box. Once again, thank you all so much for coming. I hope you learned. I hope you enjoyed this presentation. And yeah, see you next time. So I'll take questions in the chat box. Let me just open it. Chat. Here we go. Yes, we do have. This session is recorded. Last one wasn't recorded. So for recordings, you please reach out to Physiogram. I am not in charge of administrative stuff. I'm only in charge of range of motion. So just email Physiogram. We'll get you all the recordings, anything you need. So just reach out to them. You can just message them on Instagram. Yes. So everyone who needs, who wants the copy of the entire presentation, please reach out to Physiogram once again. So we will gladly share the link with you. So this session is recorded, but I cannot share it with you. So Physiogram will do that. Physiogram's email. Okay, yes, let me get it to you. It's physiogramworld@gmail.com. Physiogramworld@gmail.com. Physiogramworld. Yeah, should be that. Physiogramworld@gmail.com. You can also, yeah, just message them. Can you cover how students can tackle the gait as in clinical settings? Yes. So this is, unfortunately, I can't do one presentation on that just because it's so in depth, right? So I'm trying to actually do a good job on these. Ground reaction forces. Yes, I can do a presentation on ground reaction forces. Coming back, how students can tackle gait in clinical settings. Yeah, maybe I can actually do a summary of the entire gait analysis too. But the whole point of these webinars, so last time I worked on the temporal parameters, I worked on distal parameters. So all these little things you can actually utilize in a clinical setting. But I think you're right, it's good to do one big session where I just tell you what to look for and what are the variables. But knowing these basics will put you way up in terms of your observational skills for gait analysis in the clinic. But I will take it into account and probably will make a webinar on that. ACL or other surgeries rehabilitation. Yes. So what I will be doing, we made a schedule and we're still working on it. I wanted to start with Gait because Gait is great for everyone and everyone wants to analyze Gait. All of us want to be actually excellent at that. That's our job. I will be going into, I'm not sure if you're a student or you're a practicing physical therapist, I will be going into OCS prep. It's probably going to happen, yeah, in a few months. But like I said, we're going to keep up with Physiogram. We will be posting things there. But within the OCS prep, there is a lot of post-surgical rehabilitation. So I will definitely dive into that. I'm just not sure of the date yet, but I will get there. Yeah. Oh, so why is it vastus medialis specifically? Why not intermedius continue in being parallel to the sagittal plane? Great question. Vastus medialis is the first one I put down. It could have been vastus intermedius as well. It could have been vastus lateralis. They all function, so there's no specificity to it. They all function to extend the knee. So all of them will typically be active. It wouldn't be rectus femoris because once again, rectus femoris crosses two joints. It's going to cross the knee joint and the hip joint. Vastus medialis, intermedius, and lateralis only cross one joint. Therefore, they will be the first group active extending the knee. So you will see muscular activity in all of them. Yeah, that's the answer. Is it possible to discuss the treatment program or rehabilitation for mentioned cases? Yeah, absolutely. I think that would be great. And I think, once again, coming back to whoever wanted to do gait analysis in the clinical setting, I think, yeah, maybe I'll just take these cases and do a discussion on these cases and teach you how to analyze them. So I will definitely, it seems like there's a lot of requests for that. So I will definitely take it into consideration. Great ideas, guys. Great ideas. Oh, I typed it into a private message. So once again, if anybody needs, everyone, sorry. So here's the physiograms email for everyone, whoever actually wants to email them for the video recording. So I'll give you another minute. Can you go quickly? Can you quickly go through GRF again? So you can ask for a video recording of this video, but yeah, I can do it in like 2 seconds. We'll try to do it now, but let's see. So this is not ground reaction force. This is the line of gravity, right? And typically in Gait, ground reaction force corresponds to the line of gravity. So let's take a look here at the ankle. Oh, let's take a look here at the ankle joint. So whatever the line of gravity lands, typically it has to land either through the joint or very close to the joint axis. If it lands too far away from the joint, it will require excessive muscular activity. Same thing with the ground reaction force during Gait. So if it lands anterior to the joint axis, it will pull the proximal bone anterior. If it lands posterior to the joint axis, it will pull the proximal bone posterior. So by playing around with ground reaction forces or the range of motion in Gait, we will know which muscles will be active. So for the ankle joint, for instance, the line of gravity lands anterior to the ankle, which wants to pull the tibia and fibula anterior, which creates, you can see here, if you approximate the proximal segment, it will create a dorsiflexion moment. If it creates a dorsiflexion moment at the ankle, and that's an external force that's acting, we need to stand in neutral. So we need to use our plantar flexors to counteract that. And that's, I will make a specific webinar on ground reaction force, but that's exactly what's happening in Gait as well. So if you take a look at this patient, for instance, the line of gravity, the ground reaction force, lands anterior to the axis of rotation of the joint. Because it lands anterior to the axis of rotation of the joint, it wants the tibia and fibula to move anterior into dorsiflexion, which creates an external dorsiflexion moment. What we need to do to maintain our balance and to prevent our body from collapsing, our ankle joints, we need to use musculature that's posterior to the axis of rotation. So we will use all the musculature here. The primary muscle, our go-to, will be the soleus because it has the largest cross-sectional area and it only crosses one joint. And then the secondary muscle that we will go to is the gastrocnemius. In the next webinar, I think I will be covering range of motion and the ground reaction force. And so now you know which muscles are actually active. But I will be covering how the muscle is actually active. Is it eccentric? Is it concentric? And how do we know which one is what? But that's, yeah, stick around for the next webinar. But I hope that explained it. If anything, you can always just ask email Physiogram World and we'll get you another video of the ground reaction force. Alrighty, everyone, I will be ending this session and thank you all so much for coming. So happy for all of you to be here and I hope you learned, I hope you enjoyed it. And I will be seeing you next time during our trunk range of motion webinar. Alrighty, have a good day, everyone.